Hey everyone, let's resume with the topic of the renal system, and today we are going to understand about the nephritic syndrome. Now, nephritic means inflammation, itis. Itis shows inflammation. And now if there is inflammation in the glomerulus, there would be bleeding and that would cause hematuria. Okay, let's get one step backwards. Now what happens is that we have our nephron, and nephron has two parts, the glomerulus and the renal tubules. Now whenever the injury occurs in the glomeruli, we see red blood cell cast. And if the injury is towards the renal tubules, we see the brown granular casts, which we have discussed in the acute tubular necrosis. Now, in the when the damage is to the in the acute pyelonephritis or those obstructive conditions, during that time we have WBC casts. Okay, so keep this in back of your mind. So inflammation leading to hematuria, and because of hematuria, we see red blood cell casts, and of course we would have azotemia because the kidney function is declining, and that leads to increase in nitrogenous waste products. Recall that azotemia and uremia are different. Uremia is the symptoms of the increased nitrogenous waste products, but azotemia is a clinical condition in which the levels of the nitrogenous products are high in the blood. Then oliguria because the filtration and capacity of kidney is declining. Then yes, we would have hypertension also because there is salt retention, but this salt retention is not due to the aldosterone or RAS system. It's actually because of some intracranial mechanisms. So that should be clear. Then proteinuria is there, less than 3.5, greater than 3.5 would show the nephrotic syndrome. Periorbital edema because we have proteinuria. We also have salt retention. That all would lead to periorbital edema, which is the classic feature of any kidney disease. Now, before we begin our discussion with the various syndromes, let's first understand about the glomerular basement membrane. Now, here we have the glomerular basement membrane. Here we have the endothelial cells, and they are fenestrated, recall. Then we have our food processes of the epithelial cells, and those food processes are called podocytes. Now the GBM is divided into three parts, and that's usually seen in the electron microscopy. The center layer is electron dense, and we refer to it as lamina densa. Here we have lamina rara interna. Rara means it's light in color, and we have lamina rara externa. Externa because it's towards the epithelium, interna because it's towards the endothelium. Okay, now obviously this region would be subepithelial region, and this region would be subendothelial region. We are seeing both these regions because there are depositions over here. Okay, and one thing is that sometimes the glomerular basement membrane, um, also there is deposition, and that causes the increase in the glomerular basement membrane. So GBM can also be enlarged, subepithelial deposits can be seen, subendothelial deposits can be seen. Now, the basic morphology of any nephritic syndrome would have the hypercellular glomeruli, and you can easily understand that because we have the neutrophils, which are the inflammatory cells, and also the proliferation of the epithelial cells of the glomerulus occurs. All that is because of the inflammation. So that is causing the hypercellularity. Okay, so as I've already mentioned that nephritic syndrome is a clinical scenario that a patient would present with nephritic syndrome or nephrotic syndrome. So there are various conditions that cause nephritic syndrome. Okay, so the one of them, the first one which we are going to see is the acute proliferative glomerulonephritis, and the most important example is post-streptococcal glomerulonephritis. The PSGN is more common amongst children. Okay, and secondly, we also have some other causes like the staph endocarditis, pneumococcal pneumonia, HIV infection, malaria, and toxoplasma. Okay, but one thing I would like to emphasize over here is that in the post-streptococcal glomerulonephritis, we have IgG plus C3 deposition seen, while in case of the staph aureus or staph endocarditis, we see the IgA deposition in the glomeruli. Okay, we will touch on this again when we see the non-streptococcal causes, and discuss about the PSGN. At that time also we will see. But again, one more point I would say is that diffuse proliferation of glomerular cells. Okay, now diffuse proliferation here doesn't mean that we have a diffuse pattern of immunofluorescence. Okay, don't confuse it with that, because the diffuse pattern of immunofluorescence is seen in the Goodpasture syndrome. Okay, and that's antibody mediated syndrome, the Goodpasture syndrome, and that presents as RPGN, rapidly progressive glomerulonephritis. Okay, so this diffuse proliferation which we are talking in the case of the PSGN is actually seen in light microscopy, not in immunofluorescence. It's not an immunofluorescence pattern. I would make it very clear here that it is not an immunofluorescence pattern. In PSGN we see rather a granular pattern. Okay, a granular pattern of immunofluorescence because it is a immune complex mediated disease. Okay, now PSGN is more common amongst children, and it is seen after 1 to 4 weeks of the strep throat or the impetigo, which is a skin infection. Okay, pathogenesis involves the immune complex. Now the immune complex can be both circulating or planted. And from here, I would say that we have basically two kinds of diseases in which one is the antibody mediated mechanism and another is immune complex mediated. So either the antigen is deposited in case of the immune complex, the antigen is deposited, or the circulating complex is itself deposited. Okay, so both things can happen. Okay, now there are certain nephrogenic strains of the Streptococcus, and those are the ones producing the streptococcal pyrogenic exotoxin, and particularly the SPEB is nephrogenic. Then we also have our M protein. Now recall that M protein is the normal integral part of the cell wall, and this M protein is actually what it's a protein antigen, so it's antigenic, and it is also a virulence factor, so it inhibits phagocytosis, number one, and secondly it is antigenic. Because of antigenicity it would cause RF, rheumatic fever, and the second one is PSGN. Now the particular strains for PSGN are 1, 4, 12, and there are the other strains for the rheumatic fever. Now, yes, it's a immune complex mediated disease and it is the planted antigen. Then SP exotoxin, which I've already mentioned, activates the complement, and the complement mainly is the C3. So the C3 decreases in the blood. That's also understood. Okay, the labs would show that the ASO titer is raised. Recall that the ASO is the one of the diagnostic features of the streptococcal infection. Now let's get one step backward again and see that we have our hemolysins, and the hemolysins, recall, are two. One is the oxygen stable, which is the streptococcal streptolysin S, and another one is the streptolysin O. So we measure the antibody against the SO, and we say it ASLO or ASO. So the ASO titer would be raised, obviously, because we have our streptococcal infection. Then again, second thing is that we would have the C3 levels which are low, and that would be corresponding to the C3 deposition in the glomerulus, which along with the IgG. Okay, so that is also explanatory. Now, the basic morphology of nephritic syndrome is hypercellular glomeruli, I mentioned earlier. That's because of the infiltration of the neutrophil monocytes and the proliferation of the endothelial and the mesangial cells. Now, rarely we also see the crescent formation. We would see that crescent formation is actually the feature of RPGN. Okay, so sometimes the PSGN in case of the adults may progress to RPGN. Okay. Now here I've kept the light microscopy slide of the PSGN, and you can easily see the hypercellularity of the glomeruli, and that is all showing that we have these neutrophil cells, the monocytes. Okay, those all indicating the hypercellularity. Okay. Now in the fluorescence microscopy we see a granular pattern of immunofluorescence. How you'll to know why? Because granular pattern, let's say we have our basement membrane, then we have our endothelium, and then we have the podocytes. So the complex deposition starts from here and then comes here. So we have subepithelial humps or the subepithelial deposits. Now these complexes are not continuous, you would see, and if the disease is a antibody mediated disease like Goodpasture syndrome, in which we have antibodies against the collagen 4 of the glomerular basement membrane. Obviously, the whole basement membrane is made up of the collagen, and we would see the antibodies being attached to the whole basement membrane. So we would see rather a linear type of immunofluorescence pattern. So a granular pattern is seen in the immune complex mediated disease, and in case of the antibody mediated disease we would see a linear immunofluorescence. High to know, guys, high. Here you can see the immunofluorescence pattern of the PSGN. You can see there is no continuous type of the immunofluorescence pattern. Instead, we have a various granule type of formation, and that is the characteristic feature of the PSGN. Now, as I've already mentioned, that electron microscopy shows the subepithelial humps, and these humps start as subendothelial region and they finally reach the subepithelium. That's because, I've mentioned that the complex is dissociate and then migrate across the GBM and they finally reach the subepithelium. And so we have a particular shape, which is a dome shaped humps. They are seen in the electron microscopy. Here is the slide. See the subepithelial humps which are there, and the normal podocytes also we are not able to see, but the normal podocytes are usually formed over here. We have the dome shaped subepithelial humps. Okay, now the PSGN patient would present with the symptoms of the nephritic syndrome. Obviously that is the hematuria, RBC casts, the periorbital edema and mild hypertension. Now this hematuria would lead to a cola colored urine. Questions often mentioned about the cola colored urine occurring after the 1 to 2 weeks of the strep throat recovery, and that would also have the oliguria and malaise, fever, nausea, which are the non-specific symptoms. Now the PSGN usually resolve on its own and the treatment is supportive, but in case of the adults it may progress to RPGN or chronic glomerulonephritis, and adults may present with severe symptoms like increased blood urine nitrogen or hypertension, proteinuria, and prognosis is poorer in comparison to children. Now, the RPGN, rapidly progressive glomerulonephritis, is the second one of the nephritic syndromes which we are going to see. In this, the severe glomerular injury occurs and it's usually idiopathic, and the creatinine levels rise fast in weeks to months. Now, the hallmark feature of the RPGN is crescent formation. Okay, and this crescent formation are made up of the fibrin, and that fibrin comes from the proliferation of the parietal, that's predominantly parietal, and also visceral epithelium. Then infiltration of the monocytes and macrophages, and these 2 points are very high yield. Okay, then segmental necrosis and the sclerosis would be seen, and the GBM destruction in the electron microscopy can be seen. Okay, now here you can see the crescent formation. Here this is the crescent. Let me change the color so that you can see more clearly. This is the crescent formation. Okay, okay, so that crescent is again because of the fibrin from the parietal or visceral epithelium, mainly parietal, then also because of the neutrophil and the monocytes. Okay, now the classification of the RPGN is based on the immunofluorescence pattern. The first one, the type 1, is the antibody mediated mechanism, and that would cause the linear type of immunofluorescence, and those are formed by deposits of the IgG or C3 against the normal glomerular basement membrane structures, and that would form a linear pattern, and the example we have seen is Goodpasture syndrome. Then we have the granular type of the immunofluorescence, which is the type 2. That's because of the immune complex deposition, and the examples for this are HSP, PSGN, IgA nephropathy, Alport. All four we are going to see further in this lecture. Then posse-immune type, in which we don't know the exact cause because we are not able to identify the any antibody or immune complex, and hence the pattern is negative immunofluorescence. Now it's associated with ANCA, and can you recall that ANCA is also associated with systemic vasculitis? Then it's the most common mechanism. In fact, 20% of the patients have anti-GBM disease, 25% have type 2, and the rest are all posse-immune. We don't know the cause. Okay, now important thing is that we have to differentiate between the MP, Church-Strauss, Wegener's granulomatosis. Okay, so for that we would see p-ANCA and c-ANCA. Now what is ANCA? In ANCA, it's anti-neutrophilic cytoplasmic antibody. Now let's say we have our neutrophil, and then here is the nucleus. Now the antibodies which are formed in the perinuclear region are called as p-ANCA, and ones which are formed in the cytoplasm are called as c-ANCA. Now c-ANCA is raised in Wegener's, and the p-ANCA, from the P of the MP, we have p-ANCA raised in the microscopic polyangiitis and also in the Church-Strauss. Okay, now it's not enough to know about only the ANCA, but we also need to remember that how to differentiate between these. Now, to differentiate between the microscopic polyangiitis and Churg-Strauss, recall that Churg-Strauss is a drug-induced condition, and in drug-induced we would see bronchoconstriction-like things. So, Churg-Strauss is associated with asthma and also peripheral eosinophilia. Okay, then the Wagner's and MP are also to be differentiated. For that, the first difference is of course c-ANCA and p-ANCA. Now, second difference is that the MP involves nasopharynx, so the patient may also come with the sinusitis symptoms, while in Wagner's classically, sorry, in the microscopic polyangiitis we have nasopharynx which is spared, while in the Wagner's the nasopharynx is involved, and in the Wagner's we would have three organs which are involved, that is the nasopharynx, the lung, and the kidney. And in the MP, the nasopharynx is spared. Again, the nasopharynx is spared in case of the microscopic polyangiitis. Now, the patient would present with rapidly developing symptoms like the hematuria, RBC casts, and proteinuria. All these are the symptoms for the nephritic syndrome, but they occur very fast and develop fast. Okay. Now, hemoptysis is also seen in case of the Goodpasture syndrome. Okay. In the treatment, we would do the plasmapheresis, that's to remove the antibodies. Then we would also give steroids, and recall that steroids are also the treatment of choice in case of the vasculitis. That's because we suppress the immune system and decrease the RPGN. Then cytotoxic drugs are useful in case of the Goodpasture syndrome because we have the antibodies directly attaching to the glomerular basement membrane. Okay. Okay, so let's briefly touch on the HSP, that is the Henoch Purpura, which is a actually systemic vasculitis, and we would also see about it again in the vasculitis lectures. Now, it's the characteristic feature of HSP is that it has palpable purpura on buttocks and on extensor surfaces of arms. It is also associated with the abdominal pain and intestinal bleeding, and we would have the arthalgia with the renal abnormality. Okay, here's the picture for the HSP, and you can see that we have the purpura, the palpebral purpura specifically on the butt and on the extensor surfaces seen here, and also on the hand, the forearm. Now, Goodpasture syndrome. The Goodpasture syndrome shows a type 2 hypersensitivity reaction. Why? Because it is an antibody mediated disease, and the antibodies are against the normal collagen 4, particularly the alpha 3 chain, and the gene is col4a3. Can you recall that col4, that is collagen 4a5 alpha 5 chain, where it is involved? It is actually involved in Alport syndrome. We are going to see this in a moment. Then the hemoptysis is the feature in RPGN. Hemoptysis, why? Because the basement membrane of the alveoli is involved and the glomerular basement membrane is involved, and that is causing RPGN. Here is the immunofluorescence pattern of the Goodpasture syndrome. You can see this pattern is very linear in comparison to the granular pattern which is seen in the PSGN. So this is a linear pattern, and that linearity is because of the diffuse deposition of the immunoglobulin on the glomerular basement membrane. Now, IgA nephropathy. IgA nephropathy is one of the most common primary, I would stress, primary glomerulonephritis worldwide. Why? Um, why primary? The secondary glomerulonephritis, the most common secondary is diabetic nephropathy. Okay, so don't mix both of them. Then it's also called the Buerger's disease, and it's isolated glomerulopathy. Sometimes you may see only glomerulopathy with IgA depositions, and that's the characteristic feature actually. It is diagnostic feature that IgA deposits are seen in mesangium. Okay. Now, whenever we have IgA deposits, we would see IgA nephropathy. And as you can recall that IgA antibodies are mainly seen in the mucosal surfaces. So whenever we have these patients have the mucosal infections, after that we have the IgA nephropathy, and we say they have recurrent hematuria. And the word recurrent, whenever we say recurrent, it's important here because the infection clears, they have more increase in IgA, and that causes nephropathy. Then again it's removed. So the secondary causes are the liver disease, in which the clearance of the antibodies decrease, and intestinal disease because intestinal mucosa has IgA, and after the infection we have the nephropathy. Now, one of the high yield association is that the celiac disease patients have a increased tendency of IgA nephropathy. Now, recurrent hematuria, as I've already mentioned, because the infection clears and then they have the nephropathy. And we have C3 and Ig deposits in the mesangium. Now, to differentiate between the MPGN, which is actually a nephrotic syndrome, membranoproliferative glomerulonephritis, in that we have the C1q and the C4, which are deposited in the mesangium. Why? Because it involves the classical pathway also. Here in the IgA nephropathy, only the alternate pathways involved, and hence we see the C3 complement deposition and IgA deposition, which is the diagnostic. So in MPGN, we also have the C1q and C4, which are because of the activation of the classical pathway. And we would also see mesangial widening, which is also one of the characteristic feature, and endocapillary proliferation, that is like MPGN. So we need to differentiate it with the MPGN. Okay. Now, MPGN 1 and 2 are also there, and in MPGN 1 we have IgA, C3, C1q, C4 all, but in MPGN type 2 we only have C3, and in IgA nephropathy we have IgA plus C3 deposition. Okay, so MPGN type 1 has all three: IgG, C3, C1q, and C4. That is, it involves the complement pathway, classical and alternate also, and IgG, that is because of the membranoproliferative glomerulonephritis, that we will see further in the nephrotic syndrome video. Then the MPGN2 has only C3, and the IgA nephropathy has IgA plus C3. Okay. Now, the presentation of the IgA nephropathy would be with the recurrent hematuria, because after the infection in the respiratory or GI, which have the mucosal surfaces, and those surfaces have the IgA. So after those infection, we would see the nephropathy. Certain set of patients have CRF progression, that is renal failure, and sometimes it may progress to RPGN also. In the immunofluorescence pattern, we see a mesangial widening. Okay, and that is again the characteristic feature of IgA nephropathy. But recall, it is also seen in the MPGN type 1 and type 2, but we differentiate it on the basis of the structures which are seen, that is IgG, C1q, C3, and C4 in case of the MPGN type 1, C3 only in case of the MPGN type 2, and IgA plus C3 in case of the IgA nephropathy. Lastly, we would see the Alport syndrome. In the Alport syndrome, actually there is deficiency or defective collagen 4, and specifically the alpha 5 chain. Okay. Now, because the collagen is involved in the development of the cochlea and in the lens or cornea, they would affect these structures. Now, the most common presentation is isolated hematuria. Okay, and it also involves the cochlea, so that would lead to nerve deafness, that is there. Then the eye disorders like lens dislocation, posterior cataract, and corneal dystrophy. Okay, now the Alport syndrome may progress to RPGN, and that is the reason why we are discussing it here in the nephritic syndrome video. Okay, now the electron microscopy feature is the characteristic basket weave appearance. Okay, and that's because we have the splitting and lamination of the lamina densa. Okay, and that's because this is damaged because the collagen 4 alpha 5 chain is defective. Okay. Okay, so in summary, we have seen the post-streptococcal glomerulonephritis and the RPGN, which are the main types, or we can say the main syndromes of the nephritic syndrome. Then in the RPGN, we have seen about the Goodpasture syndrome, the Henoch Purpura, about the Alport syndrome and IgA nephropathy. Okay, and RPGN are of three types: type 1, type 2, type 3. Type 1 having the antibody mediated, having linear immunofluorescence, the type 2 having granular immunofluorescence, and type 3 the posse immune, showing no specific pattern on immunofluorescence. With this, we can conclude our lecture on the nephritic syndrome. Hope you liked it, guys. Subs if you loved it, and do subscribe the channel. See you in the next one.